Yeah, so I presented real data that we collected at the Leiden University Medical Center, and we collected data on the monoclonal antibodies. And the first thing I presented is that normally in clinical trials, we present 50% or 75% or 100% responder rates. But this is actually responder rates for each month. So each month, a different percentage of patients will be included in these groups. Whereas in clinical practice, you want to see whether there's a consistency of response in an individual patient. So I showed our data, which included patients with chronic migraine and with high frequent episodic migraine who were quite therapy resistant to previous prophylactics. And then what we actually found that for these high frequent and chronic migraine groups, we are very happy that we will reach 30% reduction in monthly migraine days for the half of the treatment period. So I indicated in this congress that I think that you should treat patients for at least 6 months. And that the threshold for success for us would be if a patient has 3 months of this 6 months of treatment period, 30% reduction or more. And many people at the congresses, they followed other meetings, and so they think that 50% reduction is easily accessible and can be reached easily in this refractory patient, which is not the case. And I think this is also very important for international guidelines, so that we do not set up the threshold too high. Otherwise, people have to stop the medication because insurance companies and taxpayers will regard them as unresponders. So I think that was one of the main things I brought to the floor. Other things that I brought to the floor is that I think it's very important that we are able to predict whether people will be responders. And we did actually 2 studies looking at prediction for response. One of them was using the trigeminal vascular system with the forehead model, which was developed at the Erasmus MC, for which we closely work together. And actually, in this forehead model, you measure actually the CGRP reactivity in the forehead as indicator for trigeminal vascular reactivity. And we found that changes in this trigeminal vascular reactivity are related to response, but also that it can be a prediction for response. So that was one thing. And the other thing is that we also measured CGRP like immunoreactivity in the serum of our patients, and also that could be a predictor for response. At the same time, I also indicated at the meeting that these 2 measurements are quite complicated, and for clinical practice, they might not be the best predictors to use. So from a pathophysiological point of view, it's good to see that you actually see that CGRP is blocked, and that the lower the level of the CGRP when people start and the more it's blocked, the more likely they will become a responder. So from that point of view, it's extremely interesting. But I think for clinical practice, we need more practical predictors. So as a third possible predictor, I present our data on depressive symptoms, where we actually show that when migraine patients have depressive symptoms, not major depression, but just depressive symptoms, which you can measure with easily accessible tools like the HOTS, for instance, that you can actually see that people who have depression are less likely to become responders. So 3 predictors for response, and I think the last one is the most practical in clinical practice. And then I also showed some results on the effect of blockage of CGRP on depressive symptoms. And I think that's quite exciting, as we saw that CGRP monoclonal antibodies do not only block migraine attacks themselves. So there is not only a reduction in monthly migraine days, but also depressive symptoms improve. And this is not due to the fact that you're treating migraine and that there are less monthly migraine days, but it seems independent of the reduction of monthly migraine days. And this might actually show that CGRP blockage might be important also for depressive disorders in general. And also as it's a comorbid condition in migraine patients, it seems to be implicated in the depressive symptoms in migraine patients. I know that there is also a study coming up from TEFA on fremanezumab, where they actually looked into the effect of blockage of CGRP in major depressive disorder. So I think the combination of looking at studies where you actually select patients with major depressive disorder or migraine patients with depressive symptoms and see that there is an effect of monoclonal antibodies who block CGRP on this comorbid condition is extremely interesting for the future. So I think that we will hear from this more the coming year. And the last thing I discussed in this real world data presentation that I provided was the effect of blockage of CGRP monoclonal antibodies on the blood pressure. And what we actually found, and this just has been recently published in Neurology, and the first author is Simone Vries-Lenz, is what we actually found is that there is an increase in blood pressure when you treat patients with iraniumab, but also with fremanezumab. So there seems to be an effect of blockage of CGRP on the blood pressure. And although in most patients this increase was significantly, but maybe not clinically relevant, we also found that in a rather small group of 200 patients, in 7 patients, we indeed needed to provide them with antihypertensive treatment. So for the clinical practice, it's extremely important that neurologists, they measure the blood pressure before starting this kind of treatments and also monitor their patients with measuring the blood pressure. And during the Congress, we had some discussion with other neurologists on how should we do that. And I said to them, well, it's not necessary that if you are not able to monitor it yourself, you can easily ask patients to go to their family doctor or monitor it at home. But I think there is a need to monitor blood pressure when you start this kind of treatment, as some of these patients really need antihypertensive treatment. Otherwise, you increase their risk for a stroke or cardiovascular event. And why is this important? This is important because migraine patients, especially young women, are more prone for stroke and cardiovascular events in general. And we don't want to increase their risk by making the blood pressure higher in those young people. So I think it's an important marker that we should take into account. And that's why we discussed that also at the European Headache Congress the past 2 days.